Welcome everybody to our last normal Egenis, regular Egenis seminar slot, because next week we have a slightly different format with a panel discussion. And I'm really pleased to welcome Rosie McVey here, who is a Egenis member and also based at the Centre for Cultures and Environments of Health in Exeter. So Rosie is a social anthropologist and particularly interested in minds, both human minds, animal minds, mental health, and I guess where those topics intersect with ethics and morality and so on, and different cultures. Rosie's first career was as a horse trainer, which any of you who came to Rosie's paper at the Beyond Cognition and Culture Group will be aware of this. And has a book based on this, which I think just lovely title, called Globetrotting, a travel on the horsemanship far off places. After Rosie did her PhD in Cambridge from 2014 to 2018, and you can read a book based on the PhD 2023 called Human Horse Relations, the Ethics of Knowing. And after that, she was teaching associate and then junior research fellowship in Cambridge. And that was a project which I'm guessing is slightly related to this.
Yes, that's what this one comes from.
Great.
Yep.
On equine therapy for UK youth. And as I mentioned, we're very lucky that Rosie's now come to Exeter for a fellowship run by the Wellcome Trust, based at the Centre for Cultures and Environments of Health. But it's also a long-standing member of Egenis and interacts a lot with what we have going on here. So we're really pleased to be here today.
Thank you very much. That's such a lovely introduction, which helps me out no end because it means I can skip my first slide. And I've got a lot to talk about today, so that's really, really great. Thanks very much for having me. I really appreciate it. It's lovely to be here talking with you all about these things. Okay, let me check my slides are going to work. Okay, so this talk begins with 14 months of ethnographic research, studying the ethical lives of equine-assisted therapy for young people. The remit of that project was to spend ethnographic time with equine-assisted therapists and find out where the ethical traction lay, what utopian moments are created, what dilemmas are navigated. And one of the most significant challenges facing the services I spent time with was the collection of data. In fact, as I spent time networking within a broader youth mental health context, it became clear that data was a problem that spread much wider than equine-assisted therapists. Services need to collect data, including demographic data, permissions, referral information, access and support needs, and more. And there are interesting ethical things to say about each of these, but today I'm going to focus on a type of data that seemed to cause the most ethical concern, but also carried the most potent sense of possibility: outcome data. Services were drawn to measure what it was that they were able to actually change. That's ethically potent because this is about formalising worth, but it's ethically challenging because, in short, outcome measures were hard to collect. The available tools, mostly questionnaires that I'll come on to shortly, didn't seem to be a good fit for the young people or the services I worked with. So questionnaires often ended up either not filled in or filled in inauthentically. And bringing record and measurement into relationships shifted the tone of those relationships in a way that some young people rejected. So this is where we're going in the talk today. Starting out with the ethnographic question, why are outcome measures hard to collect? I'll first start looking at some of the literature I can draw on to help kind of nuance that question. And I'll move slightly towards modifying the question to ask, what are the political implications of the challenges in collecting these measures? Then I'm going to give a bit more context about the complex public moral predicament faced by youth mental health data right now in the UK. And then we'll move on to a case study. It's an amalgamated and fictionalised case study, so it doesn't directly detail one identifiable case. It's more kind of brought together from a number of places. And during the case study, we'll move through a few of the issues that can come up, including the use of logic models or theory of change models, individualising and idealising wellbeing measures, the care measurement assemblage, routinized intimacy, and data roles, which I've put there in red, because if you're drifting off, wake up for that bit. That's the key part. And then embodied amenability. And then that will bring us to a short and snappy conclusion. I hope, really, the points will have been made by that point as we move through the other items. But I'll be concluding that data roles are asking too much of young people and doing too little for them. Okay, so far, more academic attention has been paid towards the workings of power when measurements are taken and audits are completed or data is processed. Then attention has been paid towards what's happening when the measures end up missing. Studies have attended to measurement and health, audit culture, studies of the datification or enumeration of morally valued goods, such as global health, public health, development and education. And this growing array of studies, as the people in this room know, has substantive breadth and depth beyond the scope of this seminar to overview. But amongst this brilliant variety is a common critical observation that inequalities in power, wealth and health can be perpetuated by measurement procedures by dint of the political distinction between those who are counted and those who do or orchestrate the counting. Often drawing on Foucauldian heritage, such studies show that power works in ways that are not immediately apparent, or at least not to those who are being measured. A classic and relevant example is Nicholas Rose's description of the way that during the second half of the 20th century, new technologies for measuring children's development and behaviour led to the formalisation of norms and the subsequent anxious appeal of mothers to experts for guidance to keep things on track. Thus, families became self-monitoring and self-managing in line with state ideals or developed governmentality. More recent examples demonstrate how new digitalised health tracking technologies can invite people to inadvertently expose themselves to biopolitical control, corporate or managerial exploitation, or loss of autonomy over their own ways of evaluating their lives. But some studies have shown that people, or rather some people in some moments, have more agency or more complex forms of agency in relation to health measurement than might be expected. Consumers of health tracking technologies might be seen as actively choosing to hand over agency to their tools, opting out of the ideal of having independent control over your own health behaviours, or is demonstrating soft resistance to metric design by each curating idiosyncratic relationships with health data differently. Other studies have shown that people can ignore or redeploy or tinker with health quantifying technologies. For example, Anne-Marie Moll demonstrated the idiosyncrasies with which people with diabetes did or didn't complete their blood sugar measurements. But despite the complex and nuanced forms of agency these authors describe, one might be forgiven for thinking that opting out of being measured indicates a position of relative power, freedom, diversity, creativity, or at least idiosyncrasy. One has somewhat escaped or defied the expectations of the data power system. However, one of the most convincing and persistent aspects of critical accounts of health measurement is their observation of the unexpected, unintentional ways that power can operate. After all, Foucault's notion of power is productive as well as restrictive. In tracking children's development, the mothers that Rose described were empowered as parents in certain ways, as well as subscribing to state power. This would mean that lack of measurement also holds possibility for subjective interpersonal action and for systemic political impact beyond individual invention or comprehension. A helpful addition here are studies of public and global health that highlight who or what is left out in the collection of legitimised health data. For example, Vincent Adams has powerfully lamented what she calls the erasure of contextualised and locally varied forms of health knowledge in what she calls the tyrannical growth of evidence-based approaches to global health. If one defies measurement in one way or another, not necessarily intentionally, but by being outside of scope, that might equate not to a position of creativity, evasion, or empowerment, but systemic neglect. One way of thinking about what data does, even when it doesn't measure, is the question of data performativity, which describes the way data can have something like agency in reshaping the understanding of problems that it sets out to investigate. Problems can become recognised by their most measurable attributes. Key questions then are who or what is excluded from data sets and how data gaps come about beyond intentional action, and what sorts of predicament follows. So taken together, these critical aspects mean when youth mental health service providers try but don't manage to get what they call good mental health data, there's an interesting political predicament at bay. Are service users escaping or defying normative measurements and forms of subjectification? And/or are they marginalised within or excluded from definitions of the problem and formulations of the solution? So this article is one part of an attention towards this predicament, which I call a predicament of unmeasurability. We're on to the context. Youth mental health data has become increasingly morally and politically pertinent in the UK in the last 3 decades. Policies aim for more complete and reliable prevalence rates, access rates, wait times, and outcome data. But while the datafication of health is often rightly understood by critics as enabling economised reasoning in healthcare, either in pursuit of state or donor efficiencies or corporate profits, there is a more complex story in relation to youth mental health. The increasing importance of data in youth mental health care can be seen as part and parcel of an expanding legitimacy for diverse ways of treating more mental distress. Faced with stark recognition of unmet needs, state agencies have had cause to more concertedly explore alternative provisions that are less traditionally clinical, particularly including those that are community-led or charity-run. This broadening aligns with the person-centred approach of the contemporary UK health policies, which emphasise patient choice, diversity, and at least ostensibly the importance of supporting health within its context. An example of that is the NHS long-term plan on the right from 2019. But also this spread into new areas of the voluntary sector enables an increase in capacity through tapping into new resources, volunteer time, charitable donations. And this expansion beyond biomedical psychiatric approaches goes hand in hand with further outcome monitoring, as Martin Pickerskill has brilliantly demonstrated. So rather than clinical qualifications like psychiatry earning legitimacy and treatment provision, the emphasis moves to services' capacities to prove their worth with outcome data. And mental health data isn't only about new possibilities and demands for garnering the legitimacy of treatments. It's also about answering to the public, including young people themselves. Within a context of public crisis in youth mental health, data has become treated as something morally potent, a tool for demanding better acknowledgement of neglected problems or people, even a medium for the witnessing of suffering and injustice. In policy documents, youth mental health data is rhetorically used to publicly acknowledge and define the extent of the crisis, and improvements in data strategy are proposed in order to chart accountability for remediating the problem at government and service levels. And mental health data has also become a backbone in advocacy groups' campaigns for better care, standing alongside or sometimes as the medium for young people's testimony. An example here is Young Minds 2023 publication. So across many of the academic, political and professional environments I visited during my fieldwork, there was a sense of endeavour that better data might lead to the right treatment and better health justice. But that hopefulness wasn't completely naive. Many of those working within mental health data were keenly aware of its weaknesses and challenges. For example, the Department of Health efforts to transform children's mental health care systems through the IACT programme emphasised the need for better outcome data as one of its core remits. But the researchers responsible for that outcome strategy were cautiously reflective about the data they were able to collect, describing it with this acronym FOPS for flawed due to missing or erroneously recorded entries, uncertain due to differences in how data items are rated, proximate in that data items are a proxy for key issues of concern, and sparse in that a low volume of cases within key subgroups may limit the possibility of statistical inference. So while good quality outcome data seem to hold moral, political and economic value, collecting good outcome data clearly presented challenges well beyond the remit of equine-assisted therapies. Conversely, and it's important to note, the UK is also a political environment where youth mental health data can be disavowed or ridiculed as newfangled fuss. Youth mental health needs can be seen by some as overindulgence, and especially scoffed at when youth mental health data relies upon self-reported measures. This is an example that I picked up during fieldwork, so that's why it's from 2016, but you could find similar examples from today, which mocks mental health statistics of young people themselves as phony and unreliable. So I want to be cautious here with what I'm doing with my analysis. My aim isn't to debunk youth mental health data as a system that doesn't produce what the talk would call matters of fact. I don't want to risk fueling the delegitimisation of unmet needs or vulnerable services. But I'm hoping to approach the problem of measuring mental health with care as a complex matter of concern and to offer observations from an ethnographic vantage point on the challenges not just of collecting good mental health data, but collecting data that can do good. So onto our case study. The Stables is the pseudonym I'm giving for this amalgamated and fictionalised case study, where a charity that provided equine-assisted therapy and education supports a large UK city in the south. Following the advice of a local authority commissioner, the Stables brought together a small team to improve their outcome data collection. And the team consisted of a clinical psychologist, a youth worker, an administrator, a co-director of the charity, and me. The plan was to add a measure that would better capture outcomes rather than just experiences, which they were already collecting in various ways. And they wanted to be able to offer something which could allow comparison for each service for different demographic groups, but also enable funders and referrers to make commissioning comparisons between services. So the Stables were keen to use a patient-reported outcome measure, or PROM. That means young people themselves, rather than mental health staff or teachers or parents, would be the ones to report on the state of their health and well-being at the start and end of the programme. For the Stables, PROMs felt like a more equitable and appropriate form of measurement than clinician-reported or carer-reported measures, particularly because the staff often found themselves disagreeing with the negative portrayals that could be reported by teachers or previous therapists or parents. And they were also really cautious about the suitability of their own perspectives as authorities on what ought to count as progress. So one of the clinical psychologists from the Stables, Peter, had recently completed some training that was really helpful for this endeavour. The training was through CAMS in improving outcome measurement. And it had introduced him to an evidence-based practice logic model, which is freely available through the Children's Outcome Research Consortium online. Completing the model, and this is a picture of the same one that we used, involved filling in 4 linked categories. The first describes the target, the people the service is for. The second describes the intervention, what does the service offer? The third is to change mechanisms, which is how your service is supposed to change something. And the fourth is for outcomes, which are measurable and visible through comparison of the same measurement at 2 or more time points. It quickly became clear this was going to be a really difficult piece of paper to fill in. And although it was increasingly printed on bigger sizes, we still couldn't fit all of the font into the boxes. And that's partly because even starting with the pink target box, the populations that the stables were trying to help was very broad. In fact, they shared only age as a common denominator. They included refugee children who visited the stables with an intermediary charity, school groups from pupil referral units who were permanently excluded from mainstream schooling, children who are either in or have experience of the care system, individual referrals through CAMS, parental referrals, mainstream school referrals. And the challenges faced were sometimes described by referrers as, obviously this is a non-exhaustive list, behavioural challenges at school or at home, trauma recovery, school refusal, selective mutism, self-harm, suicidal ideation, social skills or personal development for neurodiversities, eating disorders, obsessive compulsive disorder, conduct disorder, impulse control, challenges, and or depression. The staff didn't agree with the accuracy or utility of all of these categorisations or of any particular case of categorisation. And some people had suspected rather than diagnosed conditions, either because of long wait times or resistance from families or young people against diagnostic procedures. And even within each of the categories, the way the stables worked was too personally variable to be amenable to this logic model. One young person, for example, was able to talk about what she called her depressed feelings with a support worker while they walked through the countryside lanes with a horse for company and distraction. While another, described as depressive in her referral notes, found unparalleled comfort from the physical sensation of stroking a horse while she resisted any attempt at what she called therapy talk. It became clear that it was unviable to measure different change mechanisms for young people with different tools, not to mention statistically unwise in shrinking the population of each measure. Pragmatically, it wasn't just the issue of staff managing multiple measures for different individuals, it was also that really the ethos of the programme was that the staff would figure things out with young people through the relationship as the programme progressed, often quite experimentally and reflexively. Sometimes nobody knew what young people needed until after the event with hindsight. So change mechanisms were very difficult to predetermine so that you can have got the correct before measure. The only option that we could come up with as a team was to generalise up. So with this in mind, we landed on testing for either well-being or resilience. But one real downside to this generalising up was that profound, personally meaningful impacts could barely show up on these measures. One young man, speaking the first words uttered outside of his home in 2 years, another attending whole sessions against the backdrop of persistent disengagement, a young woman feeling safe enough to make an important disclosure, none of these showed up as improvements in a generalised wellbeing measure. Now, the stables were very committed to an ethos of contextualising rather than individualising health or pathologising suffering. And they could find some measures of wellbeing and resilience that could fit with that ethos. Asking questions about young people's environments. For example, the Child and Youth Resilience Measure asks respondents to rate from 1 to 5 how much they agree with the statement, if I'm hungry, I have enough to eat. And another, I'm treated fairly in my community. These felt like good things for the stables to be asking young people in order to really understand their well-being in a contextual way. But of course, they couldn't ask this type of detail. It was unstrategic to consider a measure that included criteria that they couldn't influence. In the end, they had to move towards well-being and resilience scales that took an individualised approach, so they had the best chance possible of moving those scores up to keep the funding coming. And that made it challenging to avoid scales that idealise certain character traits, or worse, portrayed subjective states of suffering or flourishing as social skills or public obligations. For example, the Sterling Wellbeing Scale asks respondents to rate from 1 to 10, I have always told the truth. The handling of truths may be a complex, shifting, nuanced affair for those with experience or fear of the criminal justice system or the care system, those concerned about exposing neglect or abuse, those who are victims of crimes they don't want to report or undergoing immigration investigations, or with distressing thoughts that they don't want to expose. So the top scoring ideal of always telling the truth might not only be unrealistic and ironically surely liable to misreporting, but also a poor measure of a person's capacity to navigate truth in the best way they can in an environment in order to be conducive towards positive well-being. So more broadly than the truth issue, the outcomes team struggled to find a measure that was sensitive to changes made on a one-by-one individualised intervention, but that worked on a generalised enough scale to capture all of these varieties of young people and their needs, without inappropriately idealising the sort of individual that the intervention is supposed to create, and subsequently giving a sense of negative judgment or deficiency to anyone who doesn't measure well. And that's exasperated by the before and after format of the measurement. There are some of these wellbeing scales that may not feel extremely judgmental if you imagine filling them in anonymously and randomly. This measure, for example, if it arrived through the post, might not be an easy thing to complete. This is the ONS4. But if you're given a measure like this that asks you to what extent you feel the things in your life are worthwhile, if you're given a measure like this before and after an intervention, inherently the sense of judgment is that you are supposed to be improving, and that if you value this service, that's the way that you value it for improving this scale. So several of the available scales were read like Pollyanna-ish lists of attributes, including items like, I've been feeling cheerful about things. I like everybody I have met. And I always share my sweets. These items seem so disjointed from service users' lives that the outcomes team rightly felt they risked impacting upon relationships if they delivered them. The irony and judgment inherent in this measurement system has attracted critical attention of survivor-led groups and advocates, including the group Recovery in the Bin, who created this wonderful satirical version of the Short Warwick Edinburgh scale, which opens with the item, I always eat kale. Recovery in the Bin criticise such measures as an example of what they call neo-recovery, the neoliberal appropriation of recovery movements, which they argue serve a capitalist agenda to get people back into the workforce and costing the state as little as possible. I agree, but I think the term assemblage is helpful here for highlighting that this responsibilisation is exasperated through a broad, intricate and dynamic system, socio-material system, not merely pursued by human actors like mental health staff or politicians, and not merely inscribed within cultural and discursive norms like capitalism or saturating certain biased measures like certain wellbeing scales. Of course, the term assemblage already denotes arrangements of practices, technologies and theories that configure action in socio-technical space. That particular definition is Poggles. But I find the term care measurement assemblage is helpful to critically emphasise instances where systems of care rely upon and are shaped by systems of measurement and vice versa. I hope the hyphen invites critical inquiry about the proper relationship between those two terms. At the stables, the care measurement assemblage organises flows of money, data, knowledge and people. And organising factors include the individualisation of referral systems, the availability of certain cohorts for the validation of psychometric measures, the validating power of user-reported measures, the potential leverage of scalable data, the broadening of forms of therapeutic expertise, and the need to compete for resources on the basis of change made per person per unit of time. That's quite a complex assemblage that's shaped by progressive incentives, as well as economising logics, and of course, as well as the affordances of data. So, while the outcomes team didn't want to ask young people questions that might make them feel unfavourably judged, like, I always share my sweets, they were advised by a research strategist not to shy away from asking questions with low starting scores. The temptation might have been to ask the easy questions, right? Dana explained that if you have a question that can generate a low starting score, you have a better tactical advantage in demonstrating that you're responding to a need, that there's real need there, and you have more hope of showing improvement. And she said in her experience working with charities, a persistent problem is that, in her words, needy young people measure too well at the beginning. But the outcomes team found the advice hard to follow. The more they chose a question which might capture real depth of need or suffering, the more likely they were to be dealing with sensitive, private, intimate, upsetting topics which would be rejected by those with the most acute needs anyway. The easier questions were to complete and capture a fuller cohort, a better level of data completeness, the more they're going to be skimming over the most challenging problems in people's lives. So challenging data is excluded either way. Another way to put it is some people and some problems don't bear authentic measurement within the available forms. For example, and this is a fictionalised case, 17-year-old Colette was excluded from 3 schools and becoming increasingly estranged from her adoptive mother, who she described as cold and cruel. Her younger birth sister still lived with her birth mother and had recently reached out via social media after years without contact. Colette hoped to take over parental care of her sister when she turned 18 in a few months' time, but she thought it unlikely social services would let her because she was already on a child in need plan because of intimate relationships with much older men and a lack of safeguarding in the adoptive home. Particularly, Colette didn't think social services would let her care for her sister if she continued a relationship with a much older man who she felt was the only love and support in her life, but she knew posed a risk to her sister. And she hated that her adoptive mother used the child in need plan to take what she saw as vindictive control over her life. At the beginning of Colette's therapeutic relationship at the stables, she's presented with a form and asked to rate on a 5-point scale the question, I have been feeling close to other people. How can she rate this question, and is it fair to ask her? Anthropologist Neil Armstrong uses the term routinized intimacy for the asymmetrical requirements that audit measures place on service users to bear all unreservedly as part of a procedural occurrence like form filling. The routinized intimacy involved in outcome measurement wasn't only unfair to ask of many of the young people, it was also unrealistic. Those with emotionally complex predicaments or without the required emotional literacy, or perhaps we now need the term emotional numeracy, were unlikely to be able to do it accurately or authentically, even if willing. So here, it's useful to introduce the idea that young people are expected to fulfill a role in the care measurement assemblage. I intend the term data roles to bring with it quite a strong resemblance to Talcott Parsons' term sick role and his interest in the legitimacy of health claims. Parsons argued that society accommodates those who are incapacitated as long as they're incapacitated by legitimised sickness. Society doesn't expect usual activities of them. He notes schoolwork and office work as prime examples. In return, society expects those who are ill to subscribe to medical advice and get themselves better as soon as they're able. Cases of malingering are much maligned, and overall trust endures, he says. A key actor in the maintenance of trust and social control is the physician, who personally and professionally carries authority to legitimise illness and to support the sick to play their own part in getting well. So Parsons' account is a functionalist account, and in his account, the system can look like a magnificent, delicate balance between self-interest and collective cohesion. I'm not following that functionalism, but it is important to recognise that a rhetoric of functionalism persists today empirically. For example, in the notion that data will lead to a healthy moral economy of public spending. In contrast to Parsons, though, when I use the term role now, it benefits from the critical associations I hope the term instantly evokes, thanks to Marxist and feminist terms since Parsons' writing. The term role, I hope, comes clustered by critical questioning. Role in what? For whom? To what ends? What becomes clear in relation to the care measurement assemblage I've described is that accruing worth and legitimacy is not merely a sociological process, as Parsons describes, but a socio-technical one. Incorporating STS-led observations about the power of things within systems of health and care, the term data roles can enliven the critical point that people might not only be expected to fill new sorts of measures in an era of digitalised health, rather their capacity to make legitimate claims on society for support or care or accommodation rely upon those data roles being adequately fulfilled. And a final clear departure from Parsons is necessary. It's more helpful to think of these data roles as pertaining to needs rather than sickness, which he focuses on, to incorporate more varied phenomena, as well as to embrace non-pathologizing language. We all have needs, right? But some of them have to be counted in order to count. Young people can defy the data roles expected of them. I'll talk you through how it went when we put into place the new measures that we'd chosen. The first group to fill out the new outcome measure were from a pupil referral unit I'm calling Meadow College, who provide education for young people excluded from mainstream school. The plan was for two different outcome measures to be filled in during sessions 2 and 11. Session 1 is prioritised for relationship building, and session 12 was thought trickier because young people will be transitioning out of the service. The completion was not at all straightforward. A group of 6 young people arrived by minibus, accompanied by 3 teachers. 2 young people were absent, so missed their measure that day. The minibus was 20 minutes late, having waited for a late student to arrive, and there'd been an argument on the bus. One of the young people, River, launched off the bus at speed and began pacing around the car park, occasionally darting back to the minibus to shout insults and wiping her tears on her sleeve. 2 of the others, Jaden and Charlie, were exhilarated by the outing to the stables and began approaching horses before the session was underway. When tactfully redirected by stable staff, one stole the other's coat and ran off with it. The teachers were anxious to get going with the activities quickly. They saw outcome measurement as a favour to the stables. Another young person, Derek, swayed from foot to foot, standing very near to one of the teachers and wringing his hands. He had a tic, a twist of his neck and a lift of his elbow, which was pronounced among the drama of the arrival and likely to make handwriting difficult. One teacher attempted to coax the final young person, Freya, off the bus. I could just about see across the car park through the window. She was sat on the back seat with her eyes fixed down and her jaw clenched, and she'd stay in that position for 30 minutes, not responding to multiple people's efforts to draw her into dialogue or even eye contact engagement. She would later join silently, though, and watch from the back, and her teachers would remark that this was a great success. Skillfully, the session leader, Jenny, gathered the young people, or as many as possible, around picnic benches. Jenny was supported by 2 further members of staff and the teachers from the PRU and me as volunteer. And with immense tact that many service leaders demonstrated, Jenny explained there was some paperwork to complete before the horsey activities could begin. And it was the T1, the first measure. Someone fetched a clipboard for River because she wouldn't sit with the other students. And I asked if I should take a clipboard to the minibus, but Jenny thought it was a bad idea. Freya would have to fill in the T1 measure another time, or perhaps not at all. The line between her involvement and non-involvement was too precarious to test. Charlie filled his measure in quite quickly. He was stood on a picnic bench with both feet and reaching down to fill in the form at arm's length, holding the pen by the very tip. He ticked all 4s and 5s on the 5-point wellbeing scale, though the ticks were so big, some interpretation was required, and he hadn't put his name on the sheet. When gathering the forms, Jenny mused that it was a bad idea to do the forms this week. They should have waited until Charlie was more settled. She felt his high T1 scores were inaccurate and were bound to distort the fragile overall statistical evidence of the support the stables could offer. So no matter which items were featured on that particular measure, the PROMS measure presumes that respondents are willing and able to direct their embodied attention towards a measurement task at an opportune moment. That clearly wasn't the case. Any sort of paperwork seemed physically repellent to some of the young attendees. Some held paper at arm's length, tried not to look at it or sit near it, doodled across it, dropped it in the mud, rushed it or delayed completion. Some of the stables cohorts may have had substantial, persistent experience of school-like, therapy-like, or social service-like tasks that carried unreasonable and unachievable expectations, or that made them feel unwelcome, inadequate, substandard, or like a burden or problem that needed solving. So young people's evaluative responses to these health measures, or what Pure Gartland and Neff called data valence, was entwined with their evaluative response to schooling and other forms of paperwork and authority. This means young people already most disadvantaged by systemic paper-based authority are the most likely to be marginalised by these encounters with the care measurement assemblage. And this lack of embodied amenability should be considered in a broader sense than deliberate resistance, including, for example, those not in the right place at the right time for a range of reasons, or those who feel too sick, who shake, who freeze or fall asleep. All sorts of reasons that measures aren't delivered authentically or at the right time. Some of the work the stable staff are most proud of takes place before a baseline measure can ever be captured. Or to put it another way, the baseline requires a more measurable target population than is realistic. So the data performs a more amenable population than the reality. The stable staff never withheld services from those who wouldn't or couldn't complete measures, as in the case of Freya. But they were pretty impressive in their use of tact and innovation to get measures done without too substantively disrupting relationships. This puts mental health measurement in a category that Deborah Lupton calls pushed self-tracking, meaning self-monitoring taken up more or less voluntarily, but in response to external encouragement or advocating, rather than a wholly self-generated initiative. While service leaders try to buffer service users from these uncomfortable requirements of measurement, so they tried, for example, to select the best tools they could and to implement them flexibly and tactically, and sometimes not at all. all the service leaders still hoped that enough young people could and would fulfil the role and provide good outcome measurements in order to demonstrate what they deeply felt was their value in legitimated terms. In the long run, Peter told me, perhaps reassuring himself, completing outcome measures is in their best interest. We need to make sure the services they are offered are working for them, and we need to give them a say in that. Not measuring outcomes felt unthinkable. Okay, so through analysing the data roles expected of young people in accruing legitimacy for the services that support them, I hope I've been showing that it's not only service leaders who face challenges when it comes to getting measures done, it's also service users who are put in an impossible and unfair predicament. The concept of data roles, I hope, invites critical questioning through attending to both embodied and systemic scales along two parameters. One, what do data roles ask of people? And two, what do data roles do for people? So on the first, the young people at the stables are asked to fulfil a challenging data role. It involves embodied amenability, emotional literacy and numeracy, routinized intimacy, the owning of fixable problems, the subscription to standardized normative ideals about healthy subjectivity. And young people did have the affordance not to acquiesce with these roles. They could fill them in unexpected ways, missing out items, not paying attention, rejecting routinized intimacy by ticking all fives, or not filling them out at all. And these instances shouldn't be taken as deliberate acts of resistance in every case, so much as an indication that the data roles ask more of young people than they're able or willing to afford. The data role assigned to young people expects them to be more measurable than Freya, or Colette, or Charlie. And what do these data roles do for young people systemically? While the explicit aim is the quality assurance of diverse forms of treatment and care, the risk is that young people are co-opted into building a data set that measures away the complexity of their predicaments. But if young people defy that data role through not measuring, or not measuring progress within a service that really can provide them with support, then the most complex predicaments, the most marginalised diversities, and the most inclusive services are at risk of further precarity in a competitive system that prizes evidenced fixability. Christopher Newgan calls it value capture, when people defer to data to evaluate their lives. But in the case presented here, such deferral isn't just a personal temptation on the part of service users or even service leaders. It's a compelling requirement of the way care is organised and legitimised and paid for and delivered in a care measurement assemblage. So young people are precarious in terms of public recognition of their needs, either way, whether they do or don't complete the measures. I hope that thinking with data roles will help us to stay critically attuned to how legitimacy is being configured, not through the authority of any particular person, Parsons' doctor or any politician, and not through collective agreement of a social body, either through discourse or culture or even function, but through a care measurement assemblage that might not reflect the values or needs of the people reliant upon it. Thank you.